Hi everyone! A group of 10 students just came back from AOTA 2026 in Anaheim, California. This group of students included Ava Meyer, Kennedy Woods, Paige Herringer, Reagan Hackenberry, Anne-Marie Kinman, myself, Celeste Barlow, Haley Thacker, Savannah Nally, and Courtney Brooks. We went alongside a few of our faculty, and in the next few slides you'll hear us talking about all the things that we got to see and learn during this experience.
Hi everybody, I'm Kennedy, and today I'm going to be talking about the keynote speaker. So we saw JR, and JR shared his life, and it shifted the way that I think we all in the room kind of thought about resilience, our own personal identity, and the role we play as occupational therapists. So JR Martinez had an injury, but before that he gave us a little backstory of growing up with his mom and stepping into a provider role at a very young age. So when he was younger, him and his mom, they were just in bad situation after bad situation after bad situation. And then he presented this mom with an idea. And the overall theme of this was that she was always willing to listen. They would pull up a chair and they would talk to each other. And they would just be able to have an open and honest conversation about it. So one of the things that they talked about, he really wanted to move to this new place that they had visited. He could just feel like a shift in energy and that it was going to be great. So he went and he worked at a car shop. So he paid him and his mom's rent for a long time, and it kind of shifted into when he decided he wanted to go into the military. It was that same kind of conversation. His mom, like all moms, were probably like, no, that's scary. And they had lost one of his siblings, and his mother had lost one of her other children at a very young age. So it really stood out to me that like he was carrying the responsibility and the pressure before this big event even happened in his life. So during his service in Iraq, his life completely shifted and it changed. He survived an explosion that resulted in severe burns over all of his body. And what was just powerful wasn't just the injury, it's what came after. So he talked about everything that we do as occupational therapists, about how he had to relearn to live, not just physically, but emotionally and socially. He talked about it feeling like he was placed into different boxes in his life and how he always had to make that choice to get out of that box and kind of overcome that hurdle and kind of shift the way that how he thought about himself and the limitations that kind of came with this new injury. So the overlying thing about all of this was his occupational therapist, Kim. She worked with him day in and day out at a rehabilitation place in Texas. And during the speech, he was sitting there and he was talking like, I haven't seen her in forever. I hope she's doing okay. And just really you could see how much she impacted him. So the time was running out, the keynote was concluding, and at the end, one of the AOTA people came on stage and said, what was your therapist's name again? Maybe just to give her some recognition. We didn't really know what was going on. And then they welcomed her to the stage. So Kim and JR were reunited for the first time in over 20 years. And you could see he just fell to the floor and he sunk into like all of his emotions, and it really was a moment in that room. There wasn't a dry eye in there. It was a beautiful rekindling to see. And you could feel the room shift, and you could just tell that occupational therapy became real. It wasn't about our protocols. It wasn't about our interventions. It was about impact. And you could really see the connection and the emotion between the two of them. And it really highlighted and reestablished how important our career is and how we can change and impact so many people's lives. So JR's story, really, it wasn't about just overcoming adversity. It was also about reclaiming his identity and stepping outside of his limitations and changing the direction of his life, even when it kind of felt derailed for him. And I think everybody in that room, it kind of just, that's why we love OT and that's why we wanted to be OT. And what we do always matters, not just in the moment, but the long-term effect that we have on other individuals. I know myself and all of my other peers that attended AOTA with me, we all were crying, and this was just a really meaningful and impacting keynote speaker that we were able to experience.
Hi everyone, I'm Samira Kiesling. One of the sessions that I got to sit in on was Student 107, the National OTR Certification Exam. Information you need to know. Since all of us are P3 students about to go off on our fieldwork, starting our capstones in a few months, and then starting to study for the NBCOT exam, it's going to come quick, so we were super excited about this session. The speaker was somebody who works directly with NBCOT and is always updating things as things are constantly changing. She started talking about the domains that specifically break up the exam. Domain 1, which makes up 23% of the exam, is evaluation and assessment. Domain 2, another 23% of the exam, is analysis, interpretation, and planning. The biggest portion of the exam, or Domain 3, which makes up 38% of the questions, is select and manage interventions. Domain 4, or 16% of the exam, the smallest portion, is competency and practice management. Along with understanding the breakdown of the exam, we got to do practice questions in some of these areas also to see what some questions look like to prepare us for the exam. Along with this, we got to hear some firsthand experiences from students who are currently studying for the NBCOT exam or who have recently passed, and how important it is to have somebody that you can study with, to be motivating, and also have a study plan set in place. As you can see on the screen, they took a poll of how often people are studying for the exam. It looks like most people study for about 4 hours. The speaker mentioned that this graph represents that people studied 4 hours, 5 days a week for about 6 weeks, which is a long amount of time, which is why it's so important to make sure that you're using occupational balance to make sure you're taking care of yourself while also preparing for the exam. Overall, this session was super informative, and at the end, they even handed out free flashcards and study packs to prepare people to take the NBCOT exam. Thank you so much for listening to my portion of the PowerPoint.
Hello, my name is Ava Meyer, and I'm going to talk to you a little bit about one of the sessions I attended at AOTA, known as the State of the Science Symposium. So the State of the Science is really just a session where students and practitioners can learn about upcoming research and topics that are currently being discussed. For the session I attended, the topic was the coaching connection, where evidence meets practice in occupational therapy. So it was a group of panels that spoke about this topic, and it stemmed from a planning grant collective that occurred this past October, talking about all things coaching. So what they did was split up from individuals throughout the nation that had experience and high experience in coaching. They put them into 3 different groups. There was a group for essential elements of coaching, a group for curriculum, training, and competency, and then a group for research. And they did something called a jigsaw. So the group they got together in person, talked about their set topic, and then shared with another group, got some feedback, went back with their group, and then shared to everyone. And from there, all of the studies have been talked through and came about and discussed coaching as a whole at this symposium. So what they found and what I learned is that there's a very, very high transfer rate and effectiveness of implementing coaching in comparison to training or handouts or anything of that sort. Coaching has been used in many other professions. It's been used in psychology, it's been used in education, other allied health professions as well. Another thing I learned is that they pulled a study and pulled the word coaching out of research, and of all of the articles that they found, 84% of them used coaching but did not specifically define coaching. So that was very eye-opening and shocking to me, and just proves that we need to do more research and put more out there. And if you're not familiar with coaching, it's used a lot in early intervention, so from 0 to 3, part of IDEA, Part C, and it's used there, and it's really just helping parents to understand their child, understand behaviors that their child is exhibiting, understanding their sensory needs, understanding their daily needs, their daily wants, and then helping and empowering parents to help their children. So the coaching protocol was established years ago. Dr. Scott Tomczyk had a big role in that. his coaching and education training and mentorship program. And the program is used by the state of Kentucky. Everyone goes through it. It's just mentorship. So as you begin your coaching journey and early intervention, this goes across disciplines, not just OT. You have mentorship, and you also will record yourself. The program in general for coaching with the training and mentorship lasts around 17 weeks. And you go through sessions to understand coaching, understand how to implement it. And then there's a high fidelity of coaching because every so often there's certain time frames. I forget the exact months and dates, but there's after a certain amount of months, you record one of your sessions with a family and you have to go through and document when you implemented different coaching strategies and or when you could have been doing something differently. So it just keeps everyone up to date with their coaching styles and ensures that the carryover is happening across anyone who's using coaching. I believe from what I have learned, I foresee in the future coaching potentially expanding across different areas of OT and not just as much in early intervention. It really empowers the clients' families, but I think it could empower clients as well, just to expand their own abilities and to add some more internal volition and motivations into their daily lives. And then afterwards, pictured is myself next to me, as seen on my left side, but looking at the picture on the right side. His name is Evan Dean, and it was really interesting throughout the whole conference being able to see people and meet people in person that you've only ever seen in articles. So Evan Dean has been in a few articles that I've read about employment and autism and sensory needs. So it was really interesting. I got to sit with him for the entire symposium, and off and on we were chatting, so that was really cool experience. And then on the other side of me, in the tie with the white shirt under, is Dr. Scott Tomczyk. Again, he was one of the lead panels. He was also, I'm in a program called Blend, and he was my mentor, so it was cool to reconnect with him and get to talk with him before as well as after the panel. And then on the far left side pictured is Dr. Winnie Dunn, who, if you know anything about sensory processing, she's amazing, does lots with sensory processing. So hearing from her, she was a part of the panel as well, hearing from her as a panel and then getting to talk to her afterwards was a really incredible experience. So I just really enjoyed my time at AOTA and all of the things that I got to experience, including this symposium.
At the AOTA conference, the expo hall was one of the most exciting and valuable parts of the experience. Walking through, I had the opportunity to network with occupational therapists from a wide variety of practice settings, which allowed me to hear different perspectives and learn from their real-world experiences. It was inspiring to connect with professionals who share the same passion for helping others while also gaining insight into potential career paths. The expo hall also showcased a wide range of innovative assistive technology, from adaptive equipment for daily living to advanced tools that support mobility, communication, and independence. Being able to see, interact with, and learn about these technologies firsthand made everything feel more tangible and applicable to future practice. Overall, the experience was both motivating and informative for myself, reinforcing the impact of occupational therapy and the importance of staying current with new resources and innovations.
Continuing the expo hall, there was so much assistive technology to be explored and trialed during our time walking around. The assistive technology section of the expo hall was an incredibly valuable resource to us as students. It provided us with an opportunity to explore the devices hands-on, as well as explore the latest innovations designed to help different clients across many different settings. At the expo hall, we weren't just learning about assistive technology, but we were also able to experience it. From adaptive equipment for daily living to high-tech devices, we were able to explore the hall and interact directly with the technology. I was able to trial many different assistive technologies like writing devices, virtual anatomy models, and hand therapy equipment. The first piece of equipment is here in the bottom left. It was called the Life Glove, and it's a soft robotic that helps support hand extension. It can be used for active assisted range of motion and as well as strengthening. And what makes this different is that it's powered by air instead of being mechanical. So the air pouches are on the backside of the glove and they inflate, which provides tension to extend the fingers and the hand. And here's a video of me playing an interactive game with the device with the goal of hand strengthening. So the air pockets on the back would inflate, and my goal was to flex my hand against the resistance to strengthen. And as you can see, I was flexing my hand and it was moving the ship up and down. So they have many different interactive games that clients can participate with while they are doing their exercises. Another interesting device was the Squig dynamometer. So this is the one on the right here, and it is a Bluetooth connected dynamometer that clients can use to track their hand strength and grip strength, and it provides immediate feedback through your smartphone. It provides access to data over time as well as different exercises that clients can do in and outside the clinic. Overall, exposure to all this new technology helps bridge the gap between classroom knowledge and real-world application. So it helped me get familiar with technology that we've talked about in the classroom and be able to experience it firsthand. But then I also learned a lot about new technology that I have not learned about before and that I can possibly be working with in future practice. So overall, the AOTA Expo Hall was a great tool for us to be able to experience different assistive technology, and it empowered us as future occupational therapists to be more creative, informed, and client-centered with our care. And then also, by integrating assistive technology into our practice, we can support our clients better with meaningful participation and promote independence in their everyday life. So through the Expo Hall and then also just as future practitioners, it was very nice to be informed of new technology that is out there that we can possibly use with our future clients.
One of my favorite sessions I attended was the keynote speaker, Kelsey Tainch. Kelsey's session was titled, "I'm Not Limping, That's Swagger," which focused on her patient experience as a 2-time pediatric brain tumor and stroke survivor. She took us through her journey from 5 years old when she first had cancer to remission to when her cancer came back when she was 15 years old and she experienced a stroke to now that revealed the trials and triumphs that came with her journey. She described the feeling she had when she decided she was not going to become controlled by her disability and would instead use it to empower herself. Her view now is that this life-changing experience was the best thing that ever happened to her, and she has even published a book on her story. While going through her story, Kelsey also focused on empowering the occupational therapists in the room to remember the impact that they have on patients and that they have the capability of being life changers. This session helped me learn the patient experience side of OT, the importance of empathy, and remembering the impact that I can make one day as an OT if I take each client as a unique case and build that case around their individual strengths, interests, and goals.
One of the sessions that I was able to attend was called The Clinical Evaluation of a Device to Treat Upper Extremity Lymphedema. This presentation educated us on the new device called the LymphaVibe, pictured here on the left. The LymphaVibe is a new, lightweight, portable device that uses vibration to treat upper extremity lymphedema. It uses vibration patterns, both proximal to distal and distal to proximal, to move fluid to the nearest drainage site. The device is noted to be lightweight and compact. The study demonstrated that the device was safe to use and effective in reducing both objective and subjective lymphedema burden. They completed a study using 15 participants who received treatment of the LymphaVibe and standard of care once a week for 4 weeks. They measured upper extremity circumference, induration, and lymphedema-related physical discomfort. They found statistically significant results with a decrease in circumference and in duration, which suggests the movement of fluid away from the upper extremity towards the torso, as well as revealing underlying tissue, meaning that fluid is coming off of the arm. Overall, the Lymphovibe was well tolerated by clients and had statistically significant changes. This study was aimed to gain knowledge of the possible benefits of the Lymphovibe and promote future researchers to dive deeper into this device. As a student, it was nice to hear about new technology as well as the benefits of this newer device for clients with lymphedema. There is more research to be done, as stated by the presenter, but this study showed positive benefits for this device and baseline data to grow from.
Hi, I'm going to be talking about the short course titled Evidence-Based Methods to Evaluate Feeding and Eating Difficulties in Children to Support Mealtime Participation. Like I said, this is a short course given by 2 occupational therapists, one who is a new graduate. Her name is Jada, and she actually did this as her capstone project last year at the Pilar Occupational Therapy outpatient clinics that are our pediatric clinics, and Jada, like I said, uses as her capstone to not only help the patients but mainly to educate the providers. So all the practitioners in the clinic, this gave them an insight about more of how to evaluate feeding and how does the results from that evaluation really transform into mealtime participation. So this looked at many different things. I included a few pictures here, including questions that were asked to the parents beforehand, some tongue-tie resources, and then what to bring to a feeding evaluation, because some things are just new to others, and I just think it was very interesting to see how much the occupational therapists were getting trained on this and how new programs and new ways to evaluate children change every day.
Current dementia care often leads to occupational deprivation, where individuals experience high levels of boredom and reduced participation in meaningful activities. When transitioning into long-term care, people frequently show a decline in activity engagement compared to when they were living at home. As the diagnosis progresses, others tend to take over tasks, which further reduces autonomy and limits opportunities for engagement. A major issue is the traditional risk-averse approach. This model prioritizes safety by avoiding risks, but it often focuses only on physical safety and ignores emotional, social, and psychological needs. As a result, individuals may lose independence, self-esteem, and sense of identity, ultimately becoming more dependent. A rights-based approach shifts this perspective by emphasizing that individuals with dementia still have the right to make decisions about their lives and to participate in meaningful occupations. It supports autonomy, dignity, and overall well-being, even when some levels of risk are involved. Intervention should focus on creating opportunities for engagement, such as leaving out meaningful items, initiating group activities, and fostering social participation. Staff education is critical, especially around positive risk-taking, safe mobility, and understanding client motivation. Multisensory environments can help calm individuals while allowing engagement with low cognitive demands and improving ADL performance. Outdoor activities, including gardening, have been shown to improve motivation, social interaction, and overall well-being, while also reducing agitation and even fall risk. Music-based interventions are also highly effective. Active participation, like singing or playing instruments, can improve cognitive function. Singing programs have shown improvements in verbal recall lasting up to 3 months, while listening to music can immediately trigger memories. Finally, caregiver education is essential, supporting both the caregiver and the client, as the DIAD helps ensure that activities are appropriately adapted and that social and environmental demands are modified to promote continued participation.
One of the sessions that I attended at the AOTA conference was titled Advancing Students' Understanding of Specialty Populations in Acute Care Through Simulation, Exploring the NICU and ICU. This session focused on how simulation can be used in occupational therapy education to better prepare students for high-paced settings like the NICU and ICU. The goal is to build both competence and confidence through hands-on, realistic clinical scenarios. The presenters emphasized that simulation allows students to practice skills in a safe, controlled environment before working with real patients. These simulations are designed to mimic real-life scenarios, which help students develop clinical reasoning, safety awareness, and communication skills. One example we saw was an ICU simulation video. The simulations are completed one-on-one, and each simulation follows structured learning objectives. These included introduction and orientation, confirming the patient's identity, room setup and preparation, asking orientation questions, building patient rapport, establishing therapeutic relationships, describing the occupation and context, introducing graded ADLs, and in this case it was oral care, patient education and safety, and recognizing changes in patient status. One important part of this session focused on what to do when a patient cannot leave their bed. The student and patient engaged in oral care and grooming activities at bed level. The student let the patient attempt the task independently first, then provided assistance as needed. This reinforced patient autonomy while still ensuring safety. We also saw videos of an NICU simulation. In this scenario, students were expected to engage the caregiver in real-time education, monitor and respond to vital signs, demonstrate safety awareness, and apply the just right challenge. For both the ICU and the NICU simulations, the most important part is the debrief after each simulation. These students and professors used Pearl's method of debrief, which I have attached on the right-hand side of this slide. This method allows students to process what went well, what they could improve on, and how to apply what they learned in real clinical settings. Overall, this session reinforced how valuable hands-on, realistic training is in occupational therapy education.
One of the sessions I attended was Transforming Lives Together, Supporting Mother-Infant Dyads Across OT Settings. There were 3 OTs, Libby Skolnick, Jessica Peterson, Haley Chesawatsky, who developed Maternal Health OT, which is a support for mothers and infants. Libby works in a NICU. Jessica works in a mobile private practice that she owns that specializes in lactation and maternal and infant health related to breastfeeding. Haley works in a clinic that is attached to a midwifery clinic and sees women from pregnancy to postpartum. She even sometimes gets to go to some of her clients' births in their birth center. Libby founded Born to Bloom, where she empowers mothers in motherhood to help with their child's development and connection with their baby. She does numerous things like support groups, things in the community just to help support them, and provides education to them. Haley created Wild OT, where she now works. In this session, they emphasized the importance of the mother-infant dyad. They explained how they see clients and what they do in that setting, and they see the client as the mother, the infant, and then the mother and the infant as one. They explained how the mother and infant share a lot of co-occupations, and that's that third client, because they explain the first client's the mother, second client is the infant, and then third client is mother and infant. Something that I found interesting is the infant's development can be impacted by the mother's mental health. The infant can feel the stress that the mother has, and it can impact their development, and they emphasize the importance of the mother taking care of herself first in order to provide the care that the infant needs. All 3 provided a case study of what this looks like in their setting and how they can address the mother-infant and the mother and infant together. Libby explained in the NICU this is a lot of parent education on positioning, breastfeeding, signs of distress, and providing any care that the mother is able to, so the mother can feel that she's taking care of her baby rather than nurses and anybody else in the hospital providing care. And something as people may think as simple as changing their diaper. That's very important for the mother to do while their baby is in the NICU. And then Jessica explained in her setting, it's a lot of finding ways that can support the mother and infant in the home. And the case study that she talked about, the mother provided or valued going to yoga class, but it was very difficult for her to get to yoga class or to find help, or and also the baby was very attached and did not want to be put down at all and loved to be held. And she found a way to find yoga YouTube videos that she could watch at home, and the baby would do tummy time while she does yoga. So that was something that they created and found that worked for her to help support her and the baby. And then Haley explained in her case study how she can support the mother from pregnancy or while in pregnancy, and does a lot of pelvic floor exercises and strengthening. And they also use kinesio tape on their stomach to help with discomfort and pressure, and whatever the mother needs help during pregnancy that she can help with. She works with the mom then, and then after birth, postpartum, she again does a lot of pelvic floor exercises, strengthening, and positioning, breastfeeding, anything that she can do to help support the mother postpartum. And something that I found very interesting, that all three are in different settings, but they are still working on the same things to support both mom and baby. And this was very interesting to hear that they're trying to get a model published called the PPOD model that supports mom, baby, and mom and baby as one, because they should be seen as one, because they share a lot of co-occupations, and the way that the mom is feeling can impact the baby, and same for the way the baby is can impact the mom. So they go up together, and I just found this overall to be a very interesting session, and I learned a lot about the different settings and what we as OTs can do for moms and maternal health and how we can support them.